of basic principle in revision TKA. Well, I came to India in 1990 and I met Dr. Maini and Rajesh, so it was very exciting. And now, now I will I will speak in revision in general. So it's a difficult situation for the patient, for the surgeon and the team. It's very expensive in the course for instruments, extended arm, we have more infection. The outcome is not comparable with primary TKA and high complication rate. And think, how long will this patient will survive? Because it's so why do you have to revise it? And one thing we saw was very interesting. Tibial wear is not so much a problem now, but instability is still a problem. Infection before 2 years is too high. Arthrofibrosis, we have a lot, and malposition or malalignment. So we have too many early infections. So the basic principle in the revision total knee is to decide, and we confirm the indication, but we must look at the comorbidities of this patient because they are high-risk patients. We must exclude infection, and we have seen this. It's an obsession. What's the mode of failure? What's the right implant to select, and the stem for fixation? And then we start to think of the approach, implant removal, and try to do, well, I think it's difficult, revision surgery. I think you have to do workshop before. So, so we must exclude infection, and we have seen that we must have CRP, so it's very easy, and cell rate. And well, standard aspiration of antibiotics for at least 3 weeks, and then we tap the knee and for fluid, and we do a Lucas Terras test. A cell count is very important, and we see here the numbers, but we must keep the culture for 2 weeks, because we will find sometimes something, and if we look for tuberculosis, all this we must tell the lab. But if these tests are negative for infection, I think we must repeat the aspiration, and even if we repeat, I think sometimes we have to do a synovial biopsy. Okay. That's right. So what's the different type of failure? Implant failures, loosening, polyethylene wear, and the breakage, and the post of the polyethylene can wear. Functional failure, instability, post lead to instability, stiffness, and clinical failures, pain, infection, fractures, and patient failure. I think we must be very careful because there are sometimes depressed patients or they want to attract your attention. There are 3 main mechanical failures. I think the malalignment, the improper balanced polygap, and not balanced ligament. And you have secondary cases which are stiff or unstable knee, paddle tracking, early loosening, and polyethylene wear. So we must do now the planning. And planning requires X-ray. We need long leg X-ray, and we need AP and lateral view, and we need skyline view, because that will make you think of malrotation, and you have to look at if you have a stem offset, it will be very difficult to revise it. We did very often CT scan. I think CT scan are nearly always done in my patient, and interface, and we can see, and but rotational positioning, as I heard. Stress X-ray are interesting because we can see the opening here, you see, with this table, and we can see, it's very important. So then you have to select the right implant. And we will do today the classical, and this afternoon we will do the sleeve. It's very exceptional to use primary knee, but standard revision like CCK allow for PS insert for less constraint, and but for special revision we need RKH, RHK, or sometimes megaprosthesis. The rotating hinge is very important because it has a stop at 3 degrees, and when you have a hyperextension, it's very important, but no set stem. And CCK, there is no hyperextension stop, and you have the PS and CCK option. We need a CCK when both collateral are damaged, or one ligament lateral, and when dorsal capsule is insufficient, or when you don't have a good extensor mechanism which gives recurvatum, when the deformity is not correct, when you have a recurvatum, and RI type 3. Well, now we think of surgery. So, which kind of incision could you use? I think you should use the most recent and lateral, but sometimes they are too short. So I think we have to follow the rules, and if we don't want to see this complication, and I think we need plastic surgery because it's very important. Otherwise, you will finish with something like this here, lateral approach, medial approach. So it's you have to know. Well, sometimes you have to extend your approach. It's stiff knee, so you start to expose the posterior corner. You remove the insert, but you check your paddle tendon and you get enough. So you have to snip the quadriceps tendon sometimes, or you have to do dystony, tibial osteotomy. I think we use it more in Europe, or banana peel. It's very interesting, and scolioticization, but don't do quadriceps turn down because it's a big damage. Implant removal, is it cement? Do you have cement or cement? Or is it cementless? And you have to look for the keel, but you have also to look at how it's fixed, the polyethylene or the hinge, because sometimes you need special instruments, so it has to be anticipated. And if we have foreign material, well, should you do it at the same time than the total knee? Well, we have seen this already. So, well, you have 3 steps in your surgical technique. You make tibial plane perpendicular, and then you have to balance the flexion gap. You have to do a complete release to catch up the convex side, and then you do the extension. So, well, to do the you have to re-establish a tibial platform. So it's well, you have to look at the X-ray. X-ray is very important. You have to know if you can access it, and if it's disturbed. So that's very important. If you need a stem, you have to order now. So this is very important. And also, if it will lead to overhang of the tibial plateau, and you may have to use a sleeve. The flexion gap, can you use the medullary canal? And that's very important. And then do you check for the rotation position of the femur and the side? And then you look if your collateral ligaments are good. And then you look in extension. And what is very important is to keep the joint level. So, we have some solutions for bone defect. We can augment, we can use a graft. It's very important, but we must correct them because the joint level is very important. We have solution for the soft tissue. Are you able to make this knee stable? And should we use some level of stabilization and extensor problem? We will see. So we are used with the Arora classification, but now we use the three-zone fixation, which divide the anatomical zone in epiphysis, metaphysis, and diaphysis, and that's very important. And now we think with this concept, and where can we get, how can we obtain secure fixation? Well, so the solutions are very important of the bone defect, and but we must know that sometimes, well, you know, it's a bone. It's not a. We correct the bone defect, and then it will be fine. So, but if the deformity is extra-articular, that's a big problem. So, what's the treatment algorithm? Bone defect, while you use bone graft, cement, or metal to correct this bone defect, but most of the time we have to secure with stem or stem with sleeve or cone. So that's very, very important. And to do the ligament balancing, I think we must always look at the previous x-rays. We must look at the ligament before removal, after removal. We must know this ligament and the posterior capsule. Is it retracted? Is it normal? Or is it elongated? It needs to be compensated, so that's very important. And what has the previous surgeon done? Did it release a lot? And so I think it's very important. We need to assess the reference to the femur and then to assess the patella. Where we need, most of the time, we need stem, and there are different type of stems. I think it's important. Extensor mechanism, a revision for a subluxating patella is not simple and fast case to do at the end of the program. So, you have three locations. You have the patellar tendon rupture, or you have the fracture of the patella, or you have a rupture of the quadriceps mechanism. Well, reconstruction are difficult, so it's more important to try to prevent it because, well, that's a very difficult surgery. We have to do we can do conservative, but it does not work very well. Augmentation with many stitches here, but now we use mostly synthetic graft, but sometimes we have to do allograft. So that's more difficult. And it should be available, it should be. And this allowed, and you see that after it's you have bone integration of the graft with the posterior sleeve. And this patient is a backside wear. It's a huge loss. You see here. A lot of bone is missed where we revise him with this sleeve. Maybe I will use this bigger sleeve now. and we will see this afternoon. So, hello, my friends. Thank you.